refresher on the MeHI. It's a secure statewide health information exchange network. We are operated by the Executive Office of Health and Human Services. We're open to all Mass licensed providers for information sharing is allowed under HIPAA. We're governed by an HIT council. We have several advisory groups that provide input regularly. I just want to touch upon a couple of another organization that we're working with, because I know this is sort of a point of confusion. So the Massachusetts eHealth Institute ran our Last Mile program for us, which ended back in February. The goal was to increase adoption utilization of the MeHI, and that program has ended, but thankfully we have been able to secure the team to continue the efforts, and that team is with the Massachusetts eHealth Collaborative. And so this is really it's a good point to say this, because the hope is we'll be setting up more of a user support network, and the team over at MeHI will be following up with webinar attendees as needed. And as these educational sessions go along, that's sort of going to be the new way that we'll all be working together. But again, we all work together on this, and we are all closely connected. So whether you're talking to any of us from any of the organizations, we'll be able to provide you the information that you need. The important point to remember when we talk about consent for the MeHI is that unlike other HIE models, we're not a hub-and-spoke model HIE. That means we don't have a data repository of health information. Instead, we provide a secure communications channel for authorized users to send and receive health information and to connect with one another. The goals of HIE are to serve as a tool to improve healthcare quality and patient outcomes, all while controlling costs. The core services that we offer are direct messaging, which enables a secure push of information. It essentially replaces the fax machine or the USB or an insecure email. Query and retrieve enables a search and retrieval of health information, and we'll go into that a little bit more later on. So the legislation that covers consent for MeHI is Chapter 118I, Section 11, and it states that patients must opt in to the health information exchange and have that option to opt out at any time before we can use it. So, and we need to establish a mechanism in which to do that. So that's what organizations sign to when they sign our participation agreement. There are policies that outline the information around consent, and that we'll get into in a little bit later as well. So the process for opt-in is very different than opt-out, which that model basically automatically signs up a patient for the health information exchange until that patient takes required action to opt out, which is maybe it's signing a form or whatever it is that HIE requires. So the opt-in model has been tested here in Massachusetts and elsewhere, and it's really considered the preferred model in a lot of cases because it builds that patient trust and buy-in, which helps to keep the opt-in rates up. And the patient-centric approach can help boost patient engagement overall, which I think we all know can have a positive impact on patient care and health outcomes as a whole. Here are the relevant consent policies that each participant signs to. So you need to get consent to use the MeHI for that patient care, and that consent pertains solely to the use of the MeHI. That means you still need to get any and all additional patient consents required by law to share any sensitive information. Transactions that are not subject to the patient consent policy, and I will say that this is new. I don't think it's actually not in the current version of our policies and procedure document, but that's going to be released early October. So these are new. Those covered under a separate statutory authority, and this includes mandatory public health reporting, are not subject to this consent policy, nor are HIPAA-defined administrative transactions that directly support payment or anything that's sent over the MeHI between a covered entity and its business associate for the purpose of healthcare operations. Participants must have a process to allow patients to change their consent preference and to notify the MeHI. There's no duration around MeHI consent. So you can follow your existing policies when it comes to emancipated or mature minors, but to support this, and this is a new feature for query and retrieve especially, the MeHIway will automatically reset a patient's consent status on their 18th birthday, and we'll go into a little bit more on query and retrieve and how it works in a little bit. So a big issue that we ran up against as we were drafting these policies and reviewing them with the community was consent for MeHIway and changes in functionality. So in the current state, that would be, say, if you've implemented or adopted direct messaging, then you want to add query and retrieve, because really technically what the statute says is you need to get consent for the MeHIway. So that would include direct messaging. Now, for direct messaging, consent conceptually is relatively easy. You need to get permission from patients that the MeHIway can be used as a mode of exchange. But given that the nature of query and retrieve services are different, consent needs to be more robust. So the concern was that existing participants would need to reconsent their patients as they implemented query and retrieve, which a couple of our early adopters have already gone through and had to reconcile. So in the policies for go forward, we note that a participant can get general consent for the MeHIway at one time, regardless of whether or not they're implementing all of the services, including query and retrieve. So that would mean that the patient gets the understanding as to what the services are as a whole, including query and retrieve, whether or not you're going to implement it. So you could do that consent once, adopt direct messaging, and then you'll have that consent ready or your process ready to just move into a query and retrieve implementation down the road. I'll also say that when we talk about that, we thought about what new services might be coming down the pike for the MeHIway, and at this time we don't anticipate that any additional functionality is really going to require any additional consent from patients. But in the new policies and procedures, you'll see that the MeHIway does reserve the right to require additional consent if appropriate to new functionality. But again, when we looked at the roadmap, we didn't really see anything coming that would require it. Why is consent different for query and retrieve? Well, the pull model is different, and here's a sort of a quick and dirty overview as to how it works. So an admit, transfer, discharge ADT notification is sent to the MeHIway with a consent flag of yes or no. If it's a no, we dump it at the door, and if it's a yes, this is demographic information only will be captured and stored in this Enterprise Master Patient Index, or the EMPI. So from there, the patient's relationship to that organization is made viewable by search in this relationship listing service. So at that point, other participants that can locate where medical records on their patient might be located, and then make a medical request for information, either using the HIway or whatever means that they choose. Now, this is all enabled by patient consent. So again, it's not a pull model from a data repository, but what it does is with that patient's consent, their relationship to that organization is made viewable, and then you as a querying party can say, oh, okay, I'll reach out to X organization for a medical record request. So you're not pulling data from any repository. And the data that we collect, again, it's all demographic, so it's first and last name, gender, email, address, and the medical record number from the institution. We don't collect Social Security number, and that information is not stored. So basically, for consent, a patient needs to know that the healthcare organization that's using the MeHIway is going to be sending that demographic data about them to the MeHIway, which is the state. That demographic data will need to be stored by the MeHIway, and it's going to be searchable by other authorized users. The patient's relationship to that healthcare organization, meaning that the patient has received care there, is going to be published and made viewable or disclosed to other authorized users. And that organization will be enabled to use the MeHIway to make a medical record request to those other authorized users involved in that patient's care. And we also want to know as a part of, want the patients to know as a part of consent that, of course, the data is secure in transport. The MeHIway doesn't receive or store any health data. They can change their mind at any time. they have a right to receive a log of who's made requests for information, and that's something that the MeHIway can provide to our participants. And really the big sort of high-level sound bite is that, again, all of this is meant to replace insecure methods of sending and receiving information, and to help the healthcare team stay better coordinated by knowing where that patient has gone for care in the past. What's missing from all of this is that the MeHIway doesn't tell you as participants how to implement consent. The only thing that is stated is that your process needs to be auditable, and consent must be documented, among the other policies. So some participants have asked for, just tell me the process or what's the audit criteria, but we wanted to allow for flexibility because there are just multiple different organizations types out there that we want to make sure can use the MeHIway. So we want to enable them that flexibility to implement a process that's really going to work for them and for their patients. So when we say that a process should be auditable, and I say this kind of lightly, but not really. I mean, we think about more so being accountable to the patient and, being accountable to your policies and procedures and your privacy practices, and less to this, audit of some other organization coming in, right? Because you really want to make sure that your organization is protected, and your best bet in doing so is making sure that the patient is really informed of what they're signing for. So it's like, we don't want anybody going to any consumer protection agency and saying, well, I, didn't realize what I was signing for, and, that's not going to come from us. That's really going to come from how this is presented to your patients and the level of comfortability they have when they sign their consent form. So instead of requiring the specific process or any standardized forms, the MeHIway convened some key participants, early adopters, BIDMIC, Beth Israel Deaconess, and partners who you hear from today were included. We went through this for months with our advisory groups. That's providers, legal and policy, consumers, of course. They were really involved in this. And, of course, the HIT Council reviewed all of this to, the goals were to look at the legislation, look at our policies, and then create a sort of a sample, workable process that we all felt, they all felt as healthcare organizations would be workable for any organization to adapt to, and that it's a patient-centric process. So here's where the community landed. The thought was to use really simple consent language. The purpose of that is so it can be easily adapted into existing consent forms, or can be used as a standalone form. But along with that simple consent language, you want to give the patient easy to understand educational material that covers the main points of what they need to know about what the MeHIway is. You want to give them the time to review it before making their choice, and that may mean for some that they end up taking it home and then providing their consent to you at another time. Operationally, I know that gets tricky, and again, you'll hear from participants on that. But again, the goal of that is to make sure that we allow the patient to be informed as to what they're signing for, so you can just sort of move on from it and then begin to use the MeHIway. Another big point in this is that the folks on the front lines that are going to be managing consent, they need to understand what the MeHIway is as well. So we created a flexible PowerPoint that includes all of the specifics that they need to know, and certainly allows for you to add in any additional information as to the privacy and security practices at your institution, because again, the records stay with you as the participants, not by the highway. So that's ultimately something that's going to come up. But you really need to try and make sure that your front-end staff is ready to have a conversation with patients as they are given the forms before they sign. Again, all these materials are meant to be flexible, and you're able to build upon them or adapt them to your population. There's the link for all of the forms there. And I'll actually, I think we have the, yeah, so here's the sample simple consent consent language that we landed on. So again, I consent to allow my provider to use the MeHIway to disclose my medical information to other authorized healthcare organizations, right? And this is given in addition to the educational material. So here's the, this is the MeHIway provided PDF document that is also available on the website. We also have a free text Word document with all of the same information, so it can be adapted to your existing patient educational material or repurposed and branded by your organization. It really depends on how you look at it. On the one hand, you know, it would be great if a patient saw the same form at every healthcare organization. So, you know, no matter where they go, they would recognize it and say, oh, you know, it's the MeHIway. I know what that is. I'll sign it. That's great. But on the other hand, a patient may look at it and not recognize this service as being a part of what your organization provides. You know, their trusted healthcare organization, and they may see it as a state-run program that they may not want to participate in. So if you think that that might be the case, then adapting this material into a format that your patients are comfortable with and are used to seeing may be the best. Again, this is your choice. So you'll hear more on best practices and things to consider when implementing consent from Christine and Dr. Halamka, because it's certainly better coming from them than from me. But here are a couple of the things that we've heard so far. Changing your consent forms and educating your staff can take time, so you want to start early and engage all teams. And you may want to also have regularly scheduled check-ins with the team after implementing the process to review your opt-in rates and address any gaps if needed. You want to address any particular patient needs in your population, such as translation for educational material. It's not something that the state is going to provide just yet, but again, we'll see how this goes down the road. And patient participation really drives your use of the MeHIway, so without their buy-in, you're not going to see that long-term return on investment in your implementation. So if you're implementing query and retrieve, engage your vendor early if you need to, because your system needs to be able to generate HL7s with that yes consent flag to populate the RLS, and that may take some customization. You also may need to customize your registration screen to make sure that staff knows who's been consented and who hasn't. And if you're getting consent for direct messaging only, it's okay. Just remember, you know, we would need to get a new consent, you know, using the educational material to make sure your patients are aware if you do decide to implement query and retrieve. And your staff need to be able to discuss the MeHIway with your patients, and your staff needs to have an internal escalation path if they have questions. There's actually a number on the educational material that directs patients to the MeHIway, which is AKA me, which is fine, and we expect that there will be a few people from time to time that want to speak to us directly. And I will keep participants updated as those calls come in, and you know, see how we need to adjust our material or see what patients are saying. But again, the frontline staff should have an internal contact to go to first for anything that may come up, especially because many patients will be, again, prompted to ask about how data is stored by your institution and why it's being shared and things like that. On the couple of calls that I have had, it's been interesting that once I explain that the state the state doesn't collect or store their health data, and we're essentially just trying to really move away from insecure methods of information sharing, like a fax or email. There's been a general sort of aha kind of moment, and there's been some just like a genuine excitement that this is the direction that we're moving in. So that's really a main point that we want to drive home as we're discussing this with patients.